Hi, in this video, I'm going to be talking about how we treat stage 1 breast cancer. Just briefly, stage 1 breast cancer is an invasive cancer that's 2 centimeters or smaller in size with negative lymph nodes. We have other videos on breast cancer staging. So the treatment of stage 1 breast cancer involves both local regional, and I'll explain that in a moment, treatment, local regional treatment, and systemic treatment. Local regional treatment refers to treatment of the breast and neighboring lymph nodes and includes surgery and radiation. Surgery is the mainstay of treatment for stage 1 breast cancer. We generally recommend removal of the tumor and a normal rim of tissue around it. So if this is the tumor, we remove the tumor and also want to get normal tissue around it to get what we call clear margins. Another option is removal of the breast. That's called a mastectomy. So breast conserving surgery is a lumpectomy, partial mastectomy. You might even hear terms like segmentectomy. But in general, we're talking about breast conserving surgery where we keep the breast, and then mastectomy is removal of the breast. The decisions about the type of surgery for stage 1 breast cancer include your preferences and the location of the tumor. If the tumor is very close to the skin or the chest wall, we can still do breast conserving surgery, but for some people, the cosmetic outcome, that is the appearance of the breast, can be altered enough that a mastectomy, with or without reconstruction, can actually lead to a better cosmetic outcome or appearance. The other thing to know is that if you have non-invasive breast cancer throughout the breast, we can't control that disease by just removing the invasive component. So we do see people with stage 1 small tumors in an average sized breast who have a mastectomy because there's non-invasive disease elsewhere in the breast, and at this point we don't know who's going to have progression of that disease to invasive cancer. We're working on it. We'd like to decrease the number of people who have treatment requiring a mastectomy for non-invasive disease, but we're not quite there yet. If you have breast conserving surgery, in most cases we recommend radiation therapy, because we remove the disease we can see, but there may be other cells around that tumor that's been removed that could, down the road, come back. 50% of recurrences in the breast are invasive after DCIS, and in general, if you have an in-breast recurrence after invasive cancer, it is invasive disease, and that can be very distressing. So we obviously like to decrease the risk of the cancer coming back in the breast. So if you have breast conserving surgery, radiation therapy is usually considered part of the breast preserving approach. There are some people in whom we can omit radiation therapy, people with small tumors, good margins, who have estrogen receptor positive tumors, who are going to go on endocrine therapy or hormonal therapy, who are 65 and over, we can consider omitting radiation therapy. There are other people who choose to not have radiation therapy after breast conserving surgery, and they need to meet certain criteria as well. So in general, a smaller tumor with grade 1 or grade 2 histology, really good margins, who are going to go on hormonal therapy. In general, think of radiation as sort of the right hand after the left hand of surgery if you have breast conserving surgery, and ask your medical team if omission of radiation therapy is an option for you. After mastectomy with stage 1 breast cancer, most people don't need radiation therapy. The exception would be is if the tumor was in the skin or up against the chest wall, not in the skin, but bumping up right against the skin, and it was hard to get a good margin because you can't really take more skin than what's there. I want to talk a moment about lymph nodes. For us to know that somebody has stage 1 disease, we have to assess the lymph nodes. That can be with a sentinel lymph node biopsy, and in people over 70, if the tumor is small and the person's lymph nodes are negative on exam and also on ultrasound, and they're going to go on endocrine therapy, we actually can omit assessment of the lymph nodes. So women 70 and over, estrogen receptor positive disease, who are willing to take hormonal therapy with a small tumor and lymph nodes that we can't feel and don't worry about being enlarged on ultrasound, can actually get away with not having a sentinel lymph node assessment. We are trying to get better at not treating people when that benefit is low, and similarly not doing surgery on the lymph nodes if the benefit is low. Next, so I've talked about local regional therapy, which is management of the tumor in the breast, and we talked about surgery, the two different options, and radiation therapy. I'm next going to talk about systemic therapy. Systemic therapy goes through your whole system and decreases the risk of cancer coming back in other parts of the body. One would think with stage 1 breast cancer you wouldn't need systemic therapy, but we actually know, even in stage 1 disease, that women can have a recurrence, that anybody can have a recurrence, men or women, that cancer can come back. So we treat your whole body in hopes of decreasing that risk. The benefit is lower than in more advanced stages of disease, but it's still there. I'm going to start by talking about estrogen receptor positive tumors. Tumors that have the estrogen receptor are called ER positive, or hormone receptor positive if both estrogen and progesterone receptors are positive. You can watch our video about hormone receptors to learn more. But if estrogen and progesterone receptors are positive and the tumor does not have the human epidermal growth factor, or HER2 receptor, so both ER positive and HER2 negative, in people with tumors 6 centimeters and over, we consider giving systemic therapy with endocrine therapy. We also consider giving chemotherapy, and there's an assay or test that can be done on the tumor to see if chemotherapy is likely to be helpful, or, as it is in most cases, less likely to be helpful. One of the brand names of this type of test is called the Oncotype DX assay. That's not done on you, that's done on the tumor itself. Let's say that comes back and it looks as though chemotherapy is beneficial. We use the least amount of chemotherapy we can use, and we have other videos on how chemotherapy decisions are made, but this test might show there is a benefit of chemotherapy. The test is just as likely, if not more likely, to show that chemotherapy is not helpful. On the other hand, endocrine therapy in these tumors is very important. It decreases the risk not only of the cancer coming back in other parts of the body, but also in the breast itself. So endocrine therapy is considered in people with stage 1 estrogen receptor positive tumors, regardless of the HER2 status, and the Oncotype assay or other assays similar to that can be done if the tumor is estrogen receptor positive and HER2 negative. What if the tumor is estrogen receptor positive and HER2 positive? In people with HER2 positive tumors, we do recommend 2 types of treatment: chemotherapy along with HER2 targeted therapy with a drug and similar drugs to trastuzumab. One thing we do know in stage 1 disease is that the chemotherapy can be less intensive than in people with stage 2 disease. So we can give trastuzumab along with just 1 chemotherapy drug. That's a big advance, and most people do remarkably well without their cancer coming back. What about tumors that are estrogen receptor negative, progesterone receptor negative, and HER2 negative? Those you might hear called triple negative breast cancer. Take a look at our video on triple negative breast cancer. But in stage 1 disease, even though the cancer was detected and treated early, we do know that triple negative cancers are more likely to come back than the other 2 types I've talked about, and we do recommend chemotherapy to decrease the risk of the cancer coming back and thus increasing the chance of cure. I've covered a lot in this video. I talked about what stage 1 disease is, what we think about in terms of surgery, what we think about in terms of radiation therapy, systemic disease, including chemotherapy, HER2-targeted therapy, and endocrine therapy. I hope this has been helpful to you. If it has, click like and subscribe. You can always comment or ask a question below. Follow us on Instagram, and as always, you can go to yerbba.com to get your personalized report.